Welcome everyone to the May 2020 edition of the Pre-Hospital Care Research Forum Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it's the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. And here at the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Remley Crow, and today I am joined by Dave Page, Dr. Tony Fernandez, and Dr. Bill Toon. We're also really excited to have some special guests with us, including a guest facilitator and quality improvement expert, Dr. Dave Williams. Dr. Dave Williams is an independent senior improvement advisor, and his work spans healthcare education and public safety. For more than a decade, he has supported the Institute for Healthcare Improvement as a quality expert, and he serves as lead faculty for the Improvement Advisor and Chief Quality Officer Professional Development Programs. Perhaps most importantly, he is a recovering paramedic. We also have two guests with us who authored the paper that we're reviewing, Dr. Erin Hoehn and Katie Cabrera. Again, the name of the article we are reviewing this month is Enhancing CPR During Transition from Pre-Hospital to Emergency Department, a Quality Improvement Initiative, and this is published in Pediatrics. As always, this discussion is paired with an article written by our very own columnist, Dr. Tony Fernandez, in EMS World called Journal Watch. And we encourage our listeners to check out this article at emsworld.com under the category of Education and Training. Thank you all for joining us today. And as we begin, I want to remind the audience that those of you who are listening live can use the chat feature on your screen to type in questions and comments, and we're going to bring those into the discussion as we go. With that, here we go. I'd like to extend another warm welcome to our authors and our special guest moderators. Thank you all so much for taking the time to be here with us today.
Yes, thank you for having us.
Well, and before we dive right in, I think it would be great if our guests could take a moment just to introduce themselves. So I'll start with our authors, Dr. Hoehn and Katie Cabrera. If you could just tell us a little bit about yourselves, where you're from, where you work, your favorite kind of taco, you know, the usual.
Great. Well, I'm Erin Hoehn, and I am about 2 years out of fellowship right now, so I'm a junior faculty member. I'm currently at Children's Hospital of Pittsburgh, but I did all of my training and my first 2 years of faculty life at Cincinnati Children's Hospital, and that is where this work was done. I moved here to Pittsburgh mainly for family reasons. My husband is a physician as well, and he's doing some more training out here. And my favorite type of taco currently, I guess, would be shrimp tacos that we get from a great spot in Shadyside here in Pittsburgh.
Excellent choice.
Hi, I'm Katie Cabrera. I am one of the staff nurses at Cincinnati Children's in the emergency department. My background is I initially started at Cincinnati Children's on a med-surg floor here for a couple years and dabbled in travel nursing a little bit before finding my home in emergency medicine about 5 years ago. So I've been in this department about 5 years and am involved in a lot of trauma and trauma education that goes on here. And I am partial to a carne asada taco. That's probably my favorite.
Another really good choice. And now, Dr. Williams, we didn't get your favorite kind of taco, so I think we have to start there.
Well, I was trying to look up what's in it. So my current favorite taco comes from Taco Flats on Burnett Road in Austin, Texas, and it's called the Parada. And it's made with, and I'm trying to look it up real quick on the menu here, it's made with a very, very fine steak, and then it also includes, I think, some black beans and avocado, and is done nicely with a little bit of hot sauce on a flour tortilla, of course.
Now you're going to make all those who can't travel to Austin right now jealous, but I think I'll have to get one after this call. Well, I want to thank you all again for sharing your time, and I do want to highlight the actual study. I mean, taco discussions are important, but to remind the audience, the aim of this particular study was looking at a way to decrease interruptions in chest compressions during the first 2 minutes of pediatric emergency department care when there was a handoff from EMS. from the 17 seconds observed at baseline to 10 seconds over a period of 12 months. And so just even from the description of the aim, we can tell that this study is a little bit different from the research papers that we typically review. And this was a quality improvement project, and it was guided in some principles of improvement science. And we think that these methods are so important when it comes to creating meaningful and lasting change in EMS. So we're really glad to highlight this paper, and we're especially glad to have Dr. Dave Williams with us here to highlight some of these methods as we go along. But I want to start off with the authors, and we were having a good chat together before this podcast started. But if you could, for the audience, let's talk a little bit about how you noticed the gap that needed addressed and what made you decide to take on this project.
Yeah, sure. I can start with that. So I was noticing that when patients come in cardiac arrest, there is a lot of chaos in those first few minutes. There is a lot of conflicting things happening. The EMS team is trying to give us a report. We're trying to hear that very important report. Usually either EMS or our team is trying to take over CPR compressions. We're switching who's doing the bagging and the ventilation. We're also trying to get the monitor switched off and ours put on and get the patient moved over to our bed. So there just is a lot of chaos in that first couple minutes. And for me personally, I felt like that chaos started the whole resuscitation kind of off in a more stressful tone than potentially it had to be. So we looked to see, does it just feeling like chaos, or are we actually having some pauses and compressions that could be impactful for the patient, and could we work with that? So luckily at Cincinnati Children's, there are video cameras in all of our trauma bays that allow us to kind of see what's happening and allows us to go back in time and kind of record what is happening. So we looked back at some videos and we saw that there was some pauses, a total of about 17 seconds in that first 2 minutes, where we, neither the ED team nor the EMS team were doing compressions on the patient. We also noticed that sometimes it took us a long time to get our pads on and get that first rhythm check completed. And we thought about it, and we thought that this is something we could do better, and that doing better would potentially be impactful for the patient. And then also just really kind of decrease the stress level of the entire room during that first minutes and set the resuscitation off on a better foot.
That's excellent. I also think it would be important to understand, could you tell us a little bit about the study setting and about that care team in the hospital where this took place? This is a pretty big hospital, right?
Yes, it is. It's a very big hospital. It's a level 1 trauma center. And we have a system set up where all, similar to most fully ill patients, either medical or trauma, come through one of 3 resuscitation bays. And there is a team of providers that respond to a page that goes off that there's a patient in the trauma bay that needs immediate attention. Most of our cardiac arrest patients, that team is what is called a medical team, and it is quite a few providers. It usually involves 2 docs, 4 nurses, a respiratory therapist, 2 patient care assistants, and 1 paramedic. And rotate who is holding that pager and who responds to that team at a given time. So whenever that goes off, new team members present to take care of that patient. And then if another one comes in 4 hours later, it could be a different subset of people that respond. Yeah, so it's something that it's a lot of moving pieces and moving parts.
Absolutely, and I think that's important for understanding, the underlying process to this. And the only reason I bring up that it was, a big center is because when we're thinking about quality improvement projects, having sufficient volume of cases is often a challenge. But in this case, you do see enough of these kinds of handoffs that you were able to study that in a reasonable amount of time.
Yeah, we kind of looked back and we see about 30 a year of cardiac arrest patients on average over the last several years. So we felt like that did give a sufficient number to kind of make some changes and follow it over time and see how we did.
Absolutely. I'd like to talk a little bit about establishing your aim. So we talked about how you identified the need, but then when we're talking about an aim and picking out the measure that we're going to use to determine success, how did you all settle on your primary measure?
Sure. So the primary measure was to decrease the total time we were off the chest during that first 2 minutes. And we landed on 10 seconds. And that was mainly based out of the AHA guidelines to both minimize any interruptions in chest compressions and then minimize any interruption that is longer than 10 seconds. The reason that single pause of seconds being an important point is that there are some animal studies that show when a pause is longer than 10 seconds, the coronary artery perfusion goes down and your chances of successful resuscitation go down. So really the key point was any single pause greater than 10 seconds, but we felt as a team that we were already at only 17 seconds. We thought we could get down to under 10 seconds and kind of set that up front as our goal, as our primary goal. And then our secondary goals were the any single pause greater than 10 seconds, eliminating those or minimizing those. And then also really working to get the defibrillator pads on the patient within the first 2 minutes. So we kind of had 3 main goals and then designed our interventions around those goals.
Excellent. I think one of the things that is really important in this paper is that, you know, you outlined a SMART aim. It has all of the components, that it's something specific, it's measurable, attainable, and you put a time frame around it, which is really important. So how did you pick out the time frame of 12 months in order to look at this?
Nothing too fancy about that time frame. We just kind of felt that was a long enough time that we could design an intervention, get people on board, and then follow it over time and see if we had made a difference in that 12-month period. Also knowing that we do have about 30 arrests a year, and we had about 6 months of baseline data, we felt over the next 12 months we should be able to compare to the 6 months previous and see how we were doing. But nothing too fancy or specific about that 12 months.
Nope, but I think that's worth calling out. It's a reasonable amount of time, and you know, where you can have some checkpoints along the way. Absolutely. All right, now I'm going to move into the parts that I know people are really excited about. So I want to talk about how you came up with some theories around, you know, what kinds of changes could you make to actually affect your primary outcome? And I know that you all used a quality improvement tool called a driver diagram, and I'd like Dr. Williams to talk to us just high level look at what is a driver diagram, and then let's dive into what you all ended up putting in your driver diagram. What kinds of things did you identify? So Dr. Williams, I'll turn it to you.
Sure, thank you, Dr. Crow. So a driver diagram in figure 1 in the paper is, it's a tool that's been around for some time. I believe it's attributed actually to Dr. Tom Nolan, who created it as a way to try to be able to visually display kind of your theory of change. So that sounds, you know, all fluffy, but it's really actually a very practical tool to say, what are we trying to accomplish? And then what are the specific drivers that we think will result in that, getting to that outcome? It's having a strategy or a theory of what gets there. And that's usually built from 2 different places. So you've already heard mention of looking at evidence, so going to existing research or papers as a source for understanding what are the drivers of change, and then also we're going to hear about talking with people who are familiar with the process of doing resuscitation, like paramedics and nurses and doctors and respiratory therapists and such, of what are the things from their own experience that matter. So a driver diagram, the best way to describe it visually is if you're thinking about an organizational chart. It's kind of like an organizational chart that shows how things are interconnected, but flipped on its side. And so on the left-hand side are the goals. As already were mentioned, there are several different goals that are called process measures that are tied to specific things that you want to do like reducing the time off the chest or the time to defibrillation, things like that that are very specific drivers. And then often those are tied to a bigger or a global aim, which is ultimately decreasing the mortality in out-of-hospital cardiac arrest, which is the big aim, the sort of the ultimate thing you're trying to accomplish. But these goals are the tied to the specific things you're going to work on to get to that big aim. And then when you move to the right, it lists key drivers, very specific things that are part of your kind of theory or strategy to achieve these measurable aims, and being very, very specific in terms of defining roles or standardizing the process for transition, standardizing the process for how the defibrillator gets placed. And these are the specific things that you say, I have a strong degree of belief if we do these things based on the evidence or our experience, we'll get the results that we want. And then often attached to the farther right are specific interventions. So if we say something like, hey, we want to standardize the process for CPR transition, that might be something we want to accomplish. It's a key driver, but we may have specific interventions like training or checklists or somebody who's designated with that responsibility, different things like that, that may be the specific interventions you're going to try to accomplish that driver. So in summary, a key driver diagram is a visual display of your theory of change, the specific things that you're going to work on, that you're going to test with an expectation or a degree of belief that if we're able to do these well, we're going to get to the results that we're trying to accomplish.
Thank you. That was a fantastic overview. And now I'd like to bring it back to our authors to talk a little bit about your experience with the driver diagram. How did you go about completing one, and how did you come up with these things that we're looking at in the boxes in figure 1?
Yeah, so we started with the global aim, which just as Dr. Williams said was the big global aim is to decrease out-of-hospital cardiac arrest and decrease mortality from out-of-hospital cardiac arrest. So that's our global aim, but that's a pretty hard thing to study, especially with how high mortality is with out-of-hospital cardiac arrest. So then we looked at like what are the things that we can specifically study and measure that may ultimately lead to a reduction in mortality with out-of-hospital cardiac arrest if we study it for long enough. And that came up with the minimizing interruptions, making any single pause less than 10 seconds, and really getting those Zoll pads or defibrillator pads on the patient within the first 2 minutes. So that's how we came up with our global aim and our SMART aims. One of the reasons defibrillator pads is because that's one of the goals when we take over, is to get those pads on quickly, find out if we're in a shockable rhythm or not, and then shock the patient as soon as possible to lead to the best chance of survival. So given that early shock is a component of survival, we felt like that was a very important piece to include. The next thing we had to really kind of tease out is what patients we're going to include in this, include in the population we're studying, and we include both cardiac arrest in medical team patients and those that also come in through our trauma system, where a traumatic arrest was included in this. The patients we tried to exclude were patients that EMS had placed a mechanical compression device, and that them mainly because the process we used was very different. It wasn't one person taking over compressions from another person. It was a whole different set of choreography that we had to do to take that mechanical compression device off. So that is how we narrowed our population. And then the next thing we looked at is kind of what we thought would help achieve those aims, and that's where we came up with our key drivers. And I'm going to actually hand it over to Katie to let her talk a little bit about how we engage paramedics and patient care assistants in our ED very early in the process, as they are the ones responsible for the chest compressions and the defibrillator pad placement.
Yeah, so as Erin kind of said, while we recognize that we're all bedside providers, the people that were really involved heavily in this process needed to be our medics and patient care assistants, because they're the ones that are involved in handing off and performing CPR at the bedside. So we wanted to make sure that we got their feedback when formatting choreography, just to make sure we had the greatest chance of really succeeding at this. And we really kind of wanted to make it their process because we knew staff buy-in would kind of make everything more successful. So we started with really informal PCA and medic interviews, just about what their barriers were to efficient transition and what kinds of things they'd like to see, to get an idea of what we needed to work on. And then after that, we did some low fidelity sims with a mannequin. We would pull PCAs and medics in to kind of discuss and brainstorm what kind of choreography we could try to see if we could standardize a process to make this process less chaotic. And so after we went through a few scenarios, we kind of all landed on one choreography that seemed to work the best based on a lot of their feedback about issues with access to getting to the bedside in this scenario and communication amongst team members and what differences there were between practices among providers and things like that. So after we were able to standardize choreography, we educated our team. So that involved a lot of, so we made a video and had them review that video, as well as a PowerPoint that kind of laid out what our process was going to be. And then after they reviewed the video and PowerPoint, they needed to physically come see me or another patient care assistant who's also listed as an author, Matt Helton, and we would completely review the choreography with them and then sign them off. And during that process, we were very clear that we wanted this to be their process and that we were always open to any feedback if they had any ideas about making something better, and that we really wanted to empower them as frontline providers to make this process theirs. And as we found, once this process became more standardized, it was a lot easier for our frontline providers to speak up, because it kind of just became a little bit of a culture change where on our unit, people knew that we had these goals and we needed to get this done quickly and efficiently, and they kind of left it to our PCAs and medics to really run with it. That's kind of the quick and dirty about how we kind of did all of that. And so since then, we continue to educate staff yearly, and I think in general, it's just led to a big culture change on our unit now. So it's just become kind of our process at this point.
All right, that's great. I think there's so many good things in what was just said that I want to highlight, and I'll let the other panelists jump in as well. One of the things you said is, getting the buy-in and the support from the front line. And I think, that's an important concept. So you all weren't just a two-person improvement team, right? So could you tell us a little bit about who all you included as you were designing this improvement project, and what did that team look like?
Yeah, so I think most importantly, it was we made sure to include a patient care assistant and medic that were really interested in the project. And so it was me as a trauma coordinator and those two frontline providers, as well as Dr. Hoehn, working together. There were also, as a part of our medical resuscitation committee, a few other physicians involved, kind of helping guide us because they have more experience with QI and helping us kind of work our way through it. But it was kind of that core team that was able to come up with our choreography.
Mm-hmm.
Absolutely. I think that's such an important point, is, to get that frontline opinion. Another key point here that I think is worth highlighting is Dr. Hoehn talked a little bit about narrowing the population, and you all were very specific about what your measures were and who was included. And just as a little teaching point here, operational definitions where we define clearly what's in the numerator, what's in the denominator, are so important for a quality improvement project that takes place over time. And if you've ever heard me talk, I'm always talking about it's not good enough just to compare apples to apples. We need to be comparing Macintosh apples to Macintosh apples. And I think that's something that you all did so well in this study, and I wanted to definitely highlight that.
Yeah, thanks for pointing that out. There were a couple things. I mentioned two of them. We eliminated patients with a mechanical compression device, but we also have two sites at Cincinnati Children. We have our base site, and then we have a satellite site that also receives patients that are in cardiac arrest. And we did start to roll this out to them, mainly because we found it to be so valuable and wanted to extend that value to the staff there as well as the patients that may present there. However, we really recognize that it's a different system there, and we did not include them in our patient population to be studied. It's something we may study going forward, but we did not lump it in as we felt the two sites were too different to really pull together.
Right. Sounds like there could be a different underlying process between those two sites.
Exactly.
Excellent. And now we've discussed a little bit about the intervention you all designed, about the creating and choreographing the transition between EMS and the ED team. Before we dive into the results, I want to ask if any of the other panelists have any other questions or key points that we want to highlight on this driver diagram before we move into some of the control charts.
Dr. Crow, this is Dave Williams. One question I just would love to ask, and when we talk about this in improvement all the time, you know, so in improvement, we often say we can bring the tools and methods of improvement to almost any problem, but where improvement happens is when we bring those tools and methods to people that have a deep understanding of the process. I really appreciated your description in your paper about the fact that you invited input from everyone, from the paramedics to those in the resuscitation team in the emergency department. Can you talk a little bit about what you learned from talking to these different stakeholders within the process and how that contributed to you developing your final key driver diagram?
Yeah, so Katie and I spent some time talking with quite a few PCAs and medics in our department about how they felt about this process, and kind of generated themes that many staff told us. And the main thing that came out is that they felt like they could do this process better if they were given the room to do so. And they often felt that nurses, physicians, other people in the room were trying to tell them to do conflicting things. And what they asked us for was to really give them the first 2 minutes of the time the patient is in the room to do their job. And they felt like they could do it well if they were given the room to do it. And we really agreed with them. So when we did their education, we did the education on the process and had them, you know, go through the process once in the trauma bay with Katie or Matt. But then when we educated our docs, we just told them that this is the process we're doing. And our ask of them was to give the medics and PCAs the first 2 minutes, just to try to be quiet and listen to report and give them the time to do that. And ask them to let them own that. So I think it was really an important piece of why this was successful, in that we listened to what they told us and really let them own it and said, okay, the docs are going to be quiet and going to give you your time as best as we can ask them to do so, even though that's challenging. And I think our docs did a decent job of letting that happen, especially as we saw things getting better and saw that transition was happening more smoothly. Everybody was more on board with letting that happen.
Yeah, and again, kind of leading back to that culture change that's kind of happened over time. Now it's very much ingrained in our team that these people need that first 2 minutes to get this done efficiently, and that if we give them the time, the quicker they can do it. So that has been a huge help from the rest of the team, allowing them to be able to have the time to complete the task.
Yeah. One other thing to kind of highlight is the way we came up with the choreography is Katie and I, along with Matt and Ben, a PCA and medic on our team, went into the trauma bay. We got out a mannequin and a stretcher and the defibrillator and the defibrillator pads, and we ran through several different potential ways we could do this. And we found some ways that if we place the defibrillator pad here, the cords don't reach across the table the way we need to, or if we set up the stool here, it gets in everybody's way. So we really ran through a few different scenarios until we came up with one that everybody liked, and most importantly, that they liked and they thought would work. And that was the one we went with and really started to test and implement.
So there's a couple of things there that I'd love to touch on. One is it's the use of a simulation or practice. Like some folks will wait until they actually get a physical patient encounter to be able to do their first test. But talk a little bit about why you thought it'd be helpful to use a mannequin, and how did that offer some early learning?
Yeah, so two ways. One, in our design of the intervention, it was really helpful to just get in there with a mannequin, with an EMS stretcher and an ED bed, and see how things worked, and just to walk through it. When I had kind of thought about it in my head, it didn't work out the same way it did with an actual mannequin and pads and cords and all of that stuff. So we definitely used it with the design of the intervention. The other thing is that we're really fortunate at Cincinnati Children's to have a great simulation program that is kind of tied in with this medical resuscitation committee that was part of this project. And we were able to run a few really cool high fidelity simulations that I'd take a minute to just describe. So we had, we would go to our stat line, which takes all of our EMS calls and then puts the pages out to the team. And they would send out a page saying cardiac arrest, ETA 5 minutes. And then we'd let the team set up, and we'd see if they kind of set up the way we wanted them to set up for this new process. And then the simulation staff, dressed in full EMS gear with a mannequin on a stretcher, would come in doing compressions. And then we'd allow the team to take the first couple minutes to see if they did the transition and how it went. So we did kind of two ways. One is in some low fidelity simulations to design the process, and then in some really kind of cool, fun, high fidelity simulations to both educate staff on the new process, see how it was going, and test it to see if our goals were achievable or not. We were able to complete about 3 of those high fidelity sims, and we did see that we were able to transition patients with about 7 to 10 seconds total off the chest. So we felt that our goal of a total time of 10 seconds off the chest was achievable, given that we were seeing it happen in the simulations.
That's great. And what you said something that some folks might miss in passing, but I think is really important. You mentioned that there were certain things that when you originally thought about it, you had a design, and then when you actually practiced it or tested it in simulation, you discovered some things that didn't match your original thought. Can you talk a little bit about that?
Yeah, I think one of the first things we thought about was having a defibrillator on the patient's right side and wanting to put the pads on the patient while they're still on the EMS stretcher, which goes to the patient, which starts on the left side of the bed. So we set that up and we realized that the cords were stretching all the way across the bed and nobody could get through, and it just was more cumbersome than it needed to be. So we switched where we put the defibrillator and how we connected the pads, and it seemed to go much more smoothly.
So what you're just
thing that I couldn't picture in my head until we did it.
Well, and it's a fantastic reflection, because one of the key arguments for doing improvement as a way to learn about improving a process is that exactly what you describe. Our normal mode is to try to plan the perfect intervention. And then we try to figure out how to sort of implement it and force fit it. But as you described, there are often things that emerge, like the relationship to equipment and the feasibility of moving a patient, or many number of things that are potentially predictable, but often not when you're planning, that just pop out at you when you're in the process of actually simulating a test. And so it's one of the strong arguments, and it sounds like in just a few iterations, 3 tests as you describe it, you were able to tweak and adapt your process to a more perfect version that you felt like you had confidence might work well with an actual patient.
Yeah.
Fantastic, thanks.
Yeah, thank you.
Hi, this is Bill Toon. This may not be the place for this, but I'm curious, how did you tie in the actual EMS providers to your process change? Did you do anything or inform them about anything or not?
Yeah, so we kind of did one main thing, because there's so many EMS providers that can potentially bring patients to our trauma bays. It's hard to reach them all. The first step of our intervention was that when the patient rolled in with the EMS team, we asked them to go to the left side of the bed, which is where they typically go. And then our PCA that was stationed on the left side of the bed was up on a stool, and that PCA's first responsibility was to say to the team, our team will take over CPR while you give report to the provider that rolled in. So right away, the first communication was from them saying, we will take over, you can step back and please give report, we're ready to listen. So that's our main way of communicating in the moment with the EMS teams. We do have an EMS liaison who is involved in this, and they did educate all of the Cincinnati EMS, but again, that doesn't reach all potential people that can bring it in. But we did try that, and we do have a liaison that was included in this.
Something else that we've started to incorporate into this practice is, as that PCA is standing on the stool, it's very overwhelming because at Cincinnati Children's, when an arrest happens, a lot of potential people are involved. So it's an overwhelming environment. So what we have that PCA do is stand up. Since they're up on that stool, they're taller than everybody else. And we have them raise their hand and direct EMS towards them and have them say, come towards me, come towards me. And then as they come up to them, they'll say, I'm going to take over CPR now. And then they immediately take over for EMS. Communication was really key in that process.
Oh, I love all of this information gathering that took place. And I'm curious, as you were developing this intervention, how long did it take to gather all of this data from the different sources and get the input and buy-in? Overall, about how long did it take for you to develop the final choreography?
It took about 6 months. We started looking at this data in July of 2018, 2018. And then we had our final choreography and education process in November, December of 2018. So about 6 months.
Excellent. All right, I know that we're anxious to see some of the results, so I'm going to turn it over for the authors to discuss some of their findings. But first, I want to ask if Dr. Williams could give us an overview of what it is we're going to be looking at, and they're called control charts.
Thanks, Dr. Crow. Yeah, so let me just explain here. And first of all, it's just wonderful to see these control charts in a paper like this. So I mentioned this particular paper does a wonderful job of kind of following a very traditional quality improvement pathway using clear set of aims or outcomes, defining a measurement system of specific measures that are tied to the processes that they want to work on, and a key driver diagram reflecting the process and the theories that they're trying to work on. In improvement, the best practice is to use something that's called a Shewhart statistical process control chart. In the wild, you'll hear it with a number of different names used. It was created by a guy by the name of Walter Shewhart back in the 30s, and it heavily influenced a lot of the science behind improvement. It's most commonly known as a statistical process control chart, or an SPC chart, although some folks who may have read a particular statistician's work might know it as a process behavioral chart, or they might know it by one of its specific names. So in the paper, there are figures 2, 3, and 4 show two charts side by side, and I'm going to refer to them as Shewhart charts for short, but Shewhart's charts are basically data over time. So if you imagine like a traditional line chart that you can make in any spreadsheet software, it's showing data reflected over time. There are a number of different types of data you can use. In this particular case, all of the data are time. So each measure is a time-based measure. It's actual measurement of time. And along the bottom which is the x-axis. One thing that's a little bit unique in these charts that's different from others is that each measure, each dot that you see on the chart is an individual case. So along the bottom, we have the dates of each patient that came in, which is different than, say, if we had it in order of weeks or months. So that's okay, that's great. That just reflects each individual case, and the dot is reflective of the measure for that case, and it's looked over time. All on the y-axis, all the measures obviously are time. This particular chart is one that's known as an XMR chart. It's also called, it has a number of different names, not very helpful, can be confusing, but an individuals chart is its common name. And basically it's called an individuals chart because of the fact that the data is looking at individual values. Each dot is just a number of some kind, and it's independent of all the other dots. And this particular chart will show the data over time connected with a line. And so it looks kind of like an EKG going without an organized pattern. It's probably more like looking at VTAC or VFib. It sort of fluctuates as we go along. And there's some lines around it. There's a goal line that they mentioned that they had some specific goals that they were trying to accomplish. So in figure 2, for example, they had a goal of 10 seconds, and so there's a green line reflecting the goal. There's a line in the middle, a center line, and that's the average, the mean. And it just tells us kind of what is the average of these data. And then there are a couple lines that throw people off sometimes. They're red dashed lines that are called upper and lower control limits. And these are not something that the folks that were doing this work just established and said, I don't want it to go higher than this or lower than that. They're actually based on the data. And the data, and there's a calculation in the background that helps look at the measurement and say, based on this, what would be normal and what wouldn't. And so the upper and lower control limits represent kind of the what is called the norm, or what would be random for these data. And there's a bunch of rules that these limits help us to apply to determine whether we've just got random data. Basically, the process or the system that we have produces these, whether we like them or not, but there's some natural variation that exists. Just like I always say, if we go back to our EKG analogy, a normal sinus rhythm is normal between 60 and 100, right? So if you have 64, 72, 83, all of those are within normal range. You wouldn't freak out about them. They're all just random within there. This is a kind of an oversimplification, but the same thing with a control chart. The data, if it's within the control limits and if it doesn't have a few other patterns, for the most part, we're looking to see if it's just randomly occurring, or if there's something that's an attributable or a special cause, something that's different. If something goes outside those limits, we might say, that's not random. That seems unusual. And we want to figure out what caused that. Sometimes that cause is something that we want to try to get out of there. It's a problem or an issue. In improvement, sometimes that causes us. We've done something. And so the change in the measure is due to the interventions that we have. And so these charts are really helpful for us to tell the difference between what is random and what is due to a cause. And that's important because a lot of times, there's an old saying, given any two numbers, one is going to be bigger or smaller than the other. If we react to the action and the up and downs of data, we might assume that there's improvement when something actually didn't happen. So this helps us to distinguish that. Now, tied to that, it's, they included something that's called the MR chart. So I mentioned this is called the XMR chart. The top chart tells us about the data and the average, and the MR chart tells us about how much movement, the moving range between these dots. For the most part, we only use this for two things: to see if there's any special cause from dot to dot, and that's important because the moving range is used to calculate the control limits of the main individuals chart. If there's no special cause in the moving range, then we kind of move on and focus in on the actual individual's data. Now, two things I'll highlight that are also killer that they've included in here. One is there's yellow boxes with annotations of specific things that happened that really kind of tell us the story. So not only do we see the data and what's happening over time with the actual measure, but they've connected it back to what's going on. So it becomes both a quantitative and qualitative story. Other thing is they've got a nice arrow on each chart that shows the direction of goodness. In other words, what direction do we want these data to go to meet our aim? And there's a nice green arrow that says this way is good. And all of them, it's good is down, less time. So I'll stop there and hand it back to you all, but I just wanted to give you kind of an overview. You can Google search, by the way, an individual's chart or an eye chart, as it's sometimes called, and you'll get a visual example of this if you don't have the slides in front of you. It's a very common chart and can be done in Excel or with some basic software. It's a great chart for a lot of types of data.
Absolutely. Thank you for that overview. It was a great explanation of what could look like a complicated tool, but is actually can be used simply and can be used meaningfully. I know that we've all been in a room with somebody who has that tendency towards celebration or despair. So, you know, your cardiac arrest save rate is 100% because you had one patient this week and the boss is cheering, and then the next week you had two, but 50% save rate, and then everybody's mad and throwing things, and it's the worst. So looking at a chart like this with the data over time and with these control limits helps us avoid that tendency to celebrate or despair over what is just normal variation. Love it. Now, I would like to turn it over to the authors to let's talk about your results. So this first chart that we're looking at here is your primary outcome, looking at total time off of the chest during the first 2 minutes of CPR. So what did you see after you started working on your intervention?
Yeah, so we started in July talking about it in the group, and the group involves several physicians that also run resuscitations. We're the same ones that are in the meeting talking about it as we are doing the team lead. So there was a little bit of some informal starting of some improvement. So you start to see some points below the line, but within normal variation early in the process. So that's the left side of the chart back in July. And then as we do more interventions, we start the CPR choreography in October, and then in November we do all the training, and then in December we complete education for the entire group. And in theory, by December of 2018, everybody should kind of be doing this process as much as possible. And we do start to see special cause variation, and there's rules for when you can determine something is special cause variation. And we established that in, I think, November of 2018, and we were able to show that our intervention likely is what contributed to the change that we're seeing. And the change was a decrease in total time off the chest from 17 seconds to 12 seconds. And that sustained over the remainder of the course of the study through July of 19. And just kind of like Dr. Williams said, there's some points above and below that line, but all within the new control limits that were established when we had special cause variation.
Fantastic. And let's talk a little bit about some of those secondary outcomes as well. So we also took a look at the length of the longest pause in chest compression. So we can go to the next slide. We'll look at the XMR chart for that one. And could you describe a little bit, did you see the same kind of tendency here? Was there improvement, or did some unanticipated consequences happen?
Yeah, this is probably my favorite one, because I think this one has the most clinical impact for the patient and quite an improvement. So when we looked at the longest single pause in compressions prior to our intervention, the average was around 14 seconds off the chest at any given time. And like I talked about in the beginning of this podcast, that can have clinical implications for the patient. Their coronary artery perfusion can go down, and your chance of return of circulation goes down. So with the intervention, we decreased that to 7 seconds, which is well below the AHA guidelines of 10 seconds. So we were pretty proud of that. And range chart below it, you can also see that before intervention, there's a lot of variability. Each of those points is the difference between the current point and the time before it. So there's a lot of variability there. And then as we go on in our intervention time, you see a lot less variation in that moving range chart.
Absolutely. Anything we're missing that you want to highlight there, Dr. Williams, before we move on to the last XMR chart?
No, the only big thing that is worth calling out is that so actually on the last chart, one of one of the things you'll note in these different charts is that there's some shifts in the average, and then also in the limits, and these are things that are based on things happening. So in the previous chart, it was an example of the data had actually shifted below what would have happened randomly by the original process, and so they were actually seeing that they had created a new level of performance with their process, and so they actually told the chart, hey, something we did here is different, and so it changed the way that the data looked. In the chart that we're looking at now, that is, as was mentioned earlier, there was much more of a change from patient to patient, and the moving range was really moving along. And then all of a sudden, the variation from patient to patient dropped from what was 50 seconds or so down to 18 seconds or so, which is a pretty significant change. And then therefore, what that resulted in was a tightening of the limits on the chart, reflecting that now the predictability of what's going on is more reliable going forward. And that's one of the key reasons for these charts. These charts are built around an idea of what's called analytic studies, which is this idea that we're trying to change the underlying system that produces the results that we have, so that we get new results going into the future, and that the charts help us to predict that, hey, if we keep going with this process, it's reasonable to assume that going forward, this new level of performance will sustain as long as we sustain the process that's creating it.
Dr. Williams, are you saying that every process is perfectly designed to get the results it gets?
Well, perfectly designed may be a little bit of an overstatement, but every process is designed in some fashion to get the results that it gets, and whether there was intent in that design varies. And so in this particular case, yeah, part of the theory behind when you're looking at data like this, if it shows that you've got random data, that means that the processor system you have is built to get that random data, whether you like it or not. And so if we want a different result, we got to change the processor system that's getting those results to get something different. And this is a good reflection of the folks doing that.
Absolutely. I think that this was an in-depth look at a process and did change the process, whereas, something like just yelling at somebody or telling them to try harder or do better rarely gets results. But when you actually dig in and do the learning like these authors have, we can see meaningful change here. And I'd like to go ahead and move to the last XMR chart just so that we can have a look at the third outcome measure, Will. And that was looking at time to defibrillator pad placement. That's a hard one to say. All right, so Dr. Hoehn, could you tell us a little bit about this outcome?
Yeah, sure. So we actually have 3 charts for this outcome. We have the XMR chart that we've looked at with the other measures, and then we also have what's called a G chart. So the X chart for this outcome measure, time to defibrillator pad placement, the average actually stayed the same throughout the course of the study period at around 92 seconds. So that was below the goal of 120 seconds, which was good, but we did not have sustained decrease from that 92 seconds. What the MR chart for this outcome shows you, though, is that we did still have significant decrease in variability. So the significant tightening around how much variability there was. The final thing we decided to look at with this outcome was something called a G chart. And a G chart looks at the number of patients you have between what is considered, quote unquote, a patient failure. So in this, it was the number of patients we had between any patient where it was 120 seconds or more to get those defibrillator pads on. Now, we don't have as many data points for this as we'd like to see, but you do see a significant change in that early process, everywhere from every 0 to 4 patients, we'd have one that was outside the goal line of 120 seconds, where towards the end of our study period, we had upwards of 11 patients in between. So the goal for this chart is up. You want more patients between what is considered, quote unquote, a failure.
So this is a good example of a chart that's used, and the purpose of it is for rare events, things that don't happen with great frequency. Now, sometimes, depending on how you look at a chart, the data on a traditional, say, individuals chart or XMR chart may not be as helpful if it's, especially in the cases like when you use percentages or certain things where data may show like large swings with small patient populations. So if you go from 20% to 40% to 80%, but your patient population is only say 3 a month, as in this case. So an alternative way to look at it is this G chart, and there are 2 different charts, a G and a T chart, that are used for rare events. And so as was mentioned, G charts look at the number of cases that met what we were trying to accomplish before we had one that failed. And so when you're looking across the bottom, you only see the dates of those that didn't meet what you were trying to accomplish. And as was mentioned, you're trying to increase the number of cases between, and that's actually what's being measured. So the chart itself, you know, measures, oh, in the first dot there were 3 cases before there was a failure, and then we went 0 cases and 0 cases, and then all of a sudden we went 4 cases, and you're trying to increase the number of cases that occur. This, if you have ever seen one of those measures in a factory where they said it's been 12 days since an injury, and you're trying to increase the number of days, it's based on the same concept, although this brings that Shewhart thinking to being able to understand. It's a very, very useful chart for rare events.
Yes, I love this way of looking at the data. And as we're rounding out our last 5 minutes together, I want to talk about what comes next, what happens after we stop the improvement project. How do we sustain this kind of change? Are there issues when new medics join the system, or how does this become part of the culture and we keep this kind of change?
Yeah, so I'll kind of talk about that a little bit. So one of the things we kind of realized as we were doing these sign-offs was that there were going to be new staff that were not familiar with the process, PCAs and medics. So we formatted like a checkoff for new staff. So every time someone starts working here, they get like an education binder, and there are required checkoffs that they have to complete. So we've included this process as one of their checkoffs that have to be completed before they're out of orientation, so that they're at least familiar that there is a process. And what we will try to do typically when we have pre-arrival notice that there's an arrest coming in is we will let them, we will try to include a more senior staff member who's able to guide the process, whether that's a medic or a PCA, they kind of have a moment before the patient comes in to talk about who's going to do what role. Have you ever done this before? Let me kind of walk you through it. So there's a lot of teamwork that's involved with that. In terms of long-term sustainability, we do a yearly checkoff, which involves a little bit more kind of low fidelity sims. We bring a mannequin in, we do a couple scenarios, not just to talk about the transition process, but to also do a little education about CPR in general with our PCAs and medics and what our goals are and what things we can improve upon. I also I continue to collect this data, and so I review every single case because, as Erin mentioned before, everything in our trauma bay is video recorded, and so I'm able to physically, myself and Matt Helton, the PCA authored on this paper, will review each case and watch not only the transition but the CPR, and then we will typically touch base with the team members that were involved in that case and talk about what went well and what we can work on to just get everybody on the same page and to get their feedback. If something didn't go that well, why didn't it go well? What are your thoughts going forward? Are there things that we can change? There's a lot of ongoing education that continues to happen surrounding the process.
I love that. All right, and now, unfortunately, we're reaching the end of this podcast, but I do want to close by just commending the authors one more time on this project and the publication. I think it's really important that when we undertake quality improvement projects like this, that we're not just keeping the findings in-house. And we all know that it's no small effort to go through the peer review publication process. So I want to thank you all for your work and for taking that extra effort to be able to share it with others. it's just a huge effort, and thank you for that.
Yeah, thank you so much, and thank you for having us. We really were excited about this project and really happy to talk about it with whoever wants to listen. So thank you for having us.
Absolutely. I think there's a lot of opportunity to perform some R&D, some rip off and duplicate on this project, not only at the point of handoff, but there's probably some good knowledge that can be applied in the pre-hospital setting around this choreography and this idea of how to modify the process.
Yeah, absolutely. I agree.
All right, so thank you all one more time, and thank you to our panelists, and a huge thank you to our guest facilitator, Dr. Williams, for sharing your expertise and helping highlight the key pieces of improvement methodology as we went along.
Thank you, Dr. Crow. My pleasure.
As a reminder, I want to tell you to join us for the Education Research Podcast that happens later this month. It'll be Friday, May 22nd at 10 Pacific, noon Central. And we are going to be right back here with our clinical podcast on the second Monday of the month, which is June 8th. Thank all of you for listening, and look forward to being here with you next time.